Hello and welcome to this live session at the Geneva Health Forum on sleeping sickness. So the theme of this year's Health Forum is, and this one, is the history of successful partnerships towards the elimination of sleeping sickness. And in these times, I'm not wearing a mask because I'm actually alone in the studio, but in these times of COVID where there's a lot of bad news, today is a good news story, thanks to a long-standing partnership between Sanofi, the Drugs for Neglected Diseases Initiative, WHO, and above all, the Ministries of Health in country. And so today we're going to hear about how this successful partnership in just 20 years has seen a 96% decline in the cases of sleeping sickness. So a huge success, 96%. You'll hear more about how this disease is really horrendous. The reason why it's called sleeping sickness is because people, when it gets really bad, they tend to sleep all day, stay up all night. It sends you crazy. And this is something that's reversed that and made it possible to look towards elimination. So without further ado, we're going to move to a short extract of a film, which is called A Doctor's Dream, A Pill for Sleeping Sickness. And this won the first prize at the WHO Health for All 2020 Film Festival. So please, let's watch this video to give you an idea. Thank you.
La maladie du sommeil, ça fait peur parce que vous avez des signes de quelqu'un qui devient fou.
Eventually, if they don't have treatment, they will fall into a coma and die.
We wanted to have an oral treatment to treat all the stages of the disease.
Sanofi had the molecule, but we partnered with the NDI, who brought the experience from preclinical research.
We had to bring electricity, microscopes, technology like internet and satellites. We supported the national programs with cars, boats, to go and look for patients. We did training of 200 people to make sure that they could comply to international standards.
If we bring the right partner together, we can achieve the best science for a very neglected population.
So as you could see, before patients even had any hope for treatment, or doctors and nurses, the disease was painful and a killer for many. And so we're very lucky today to have Dr. Francis Luis, who's the president of the Ceux de Faro Association, which is a well-respected school of tropical medicine and research in Marseille, which has set up an archive of some of these amazing photos and experiences over 100 years of dealing with sleeping sickness. So Dr. Francis Luis has 20 years of experience in country working on this terrible disease, and he's going to give us an amazing black and white photo montage of the changes that we've seen since 1920 to 2020. And these are thanks to Marcel Chambon, a French physician, and Eugène Jameau. Please, Dr. Francis Luis, over to you.
Merci Samantha, bonjour à tous. Je voudrais commencer par dire que les années 2020 marquent le centenaire de la lutte contre la maladie du sommeil. Au lendemain de la Première Guerre mondiale, les Français, avec le docteur Eugène Jameau, ont développé au Congo et au Cameroun une stratégie de lutte fondée sur les équipes mobiles. Les photos que vous allez voir datent de 1925 pour la plupart. Elles ont été prises par le docteur Jameau et le docteur Chambon, son disciple, dans la forêt du Cameroun. Ah, là, il y a un problème. Hein. C'est pas la première.
Il faut continuer.
La première, c'est...
Il faut continuer et puis vous parlez sur les photos qui sont montrées, mais il faut dire changer la photo. Merci.
D'accord. En 1920, la stratégie de lutte par les équipes mobiles n'était pas du tout une évidence. Il n'y avait pas de route, pas de voiture, les équipes de 20 à 40 personnes qui portaient tout le matériel allaient de village en village, en pirogue, sur les rivières bien sûr, ou à pied, sur des pistes à peine tracées. Le voyage en pirogue était long, monotone, et c'était une véritable épreuve pour les Européens qui n'étaient pas habitués à ce type de déplacement. Il faut noter en plus qu'ils étaient assaillis par des insectes de toutes sortes et que la traversée des rivières était parfois une épreuve vraiment difficile. Le deuxième moyen, c'était de prendre la piste. La piste était à peine tracée, les gens se déplaçaient à pied, cela durait des heures et ils arrivaient dans les villages complètement exténués après avoir franchi des marigots, emprunté des ponts plus que rudimentaires. Dans les villages, toute la population était réunie, recensée et examinée. Le diagnostic reposait sur la palpation et la ponction glandulaire, des adénopathies cervicales, voilà l'image. Ensuite, tous les habitants subissaient une prise de sang au bout du doigt et ces examens étaient examinés au microscope monoculaire. Quand un habitant était trouvé positif, il fallait à ce moment-là qu'il passe à la ponction lombaire. Je tiens ici à dire que cet examen se faisait dans l'asepsie la plus stricte, avec des aiguilles parfaitement stériles. Les résultats de la ponction lombaire décidaient du traitement. À l'époque, tous les traitements étaient à base d'arsenic. Les résultats obtenus ont été si spectaculaires que les équipes mobiles ont été maintenues plus de 80 ans. Bien sûr, la stratégie diagnostique a été modifiée, mais finalement très peu. Simplement, on a intégré progressivement les nouvelles technologies microscopiques, les progrès en cytologie, tels que les mini-colonnes, et en immunologie, tels que le CAT-test en 1979. De nouveaux médicaments ont également été intégrés. Il s'agit de la pentamidine dans les années 1950, le mélarsoprol, toujours un médicament à base d'arsenic, à la fin de la Deuxième Guerre mondiale. En fait, la véritable révolution a eu lieu au XXIe siècle. En 2001, un partenariat public-privé Sanofi-Aventis a permis de disposer de tous les traitements nécessaires, à titre gratuit bien sûr. En 2009, le protocole NECT, Nifurtimox et Aflonitine Combination Therapy, a permis l'abandon de l'arsenic. En 2015, la stratégie des équipes mobiles a finalement été remplacée par une stratégie fondée sur les sites sentinelles. À la même époque ont été développés des tests rapides de sérodiagnostic et le test de triple-analyse sur sérum réservé à des laboratoires spécialisés. Enfin, depuis 2018, le fexinidazole permet le traitement précoce, et c'est très important, de la maladie du sommeil à tous les stades. Aujourd'hui, l'élimination de la maladie du sommeil comme problème de santé publique n'est plus une utopie, c'est un objectif fixé à quelques années. Et je tiens à dire que cela est déjà un résultat extraordinaire dû au travail en commun de toutes les parties prenantes, qu'elles soient nationales, régionales ou internationales. Je vous remercie pour votre attention.
Merci, Dr. Francis Lewis. Thank you, Dr. Francis Lewis, for those amazing photos and experiences. Most of the photos, the black and white, were taken in Cameroon in the 1920s. And if you would like to use those pictures or see more of them, there are 36 of them on the Global Health Forum website. And you can also get in touch with Dr. Francis Lewis to see what other amazing photos he has in his archive of neglected tropical diseases. So without further ado, as the theme of this Geneva Health Forum is improving access to health, learning from the field, we're lucky to have panelists who all have experience working in the field. And without further ado, we're going to move to the World Health Organization, to Dr. Daniel Argaud-Dagne, who's the unit head of prevention, treatment and care at the Neglected Tropical Diseases Department of WHO. Over to you. Thank you. Sorry, Dr. Daniel, you need to start. We couldn't hear you. Can you speak, please, so we can see if we can hear you?
Thank you for inviting me. Thank you, Samantha, and thank you, the organizers, for inviting me to this session that marks and celebrates a history of successful partnerships towards the elimination of sleeping sickness. Human African trypanosomiasis, or commonly known as sleeping sickness, is a life-threatening vector-borne disease transmitted by fly bites. It's one of the neglected tropical diseases with limited and complicated tools for its control and elimination. The disease occurs mainly in rural parts and only in the sub-Saharan Africa region in around 36 countries. This deadly disease in the past has caused several epidemics in many endemic countries, leading to a large number of mortalities. Humans are affected by the two forms of the disease, the Gambianse, which affects mainly humans, and the Rhodesianse affects both humans and animals, causing a significant toll to both human and animal health, including economical losses. At the end of the 20th century, sleeping sickness constituted a major public health problem in these countries, with devastating effect on the affected population. In 1995, although a WHO expert committee estimated about 300,000 new cases per year, only 30,000 cases were diagnosed and treated. In 1997, the 50th World Health Assembly expressed its deep concerns about the resurgence of cases and adopted a resolution urging member states and WHO to reinforce surveillance and control activities and calling the international communities for advocacy and resources. Subsequently, WHO and partners strongly promoted access to diagnosis, treatment, and strengthening the surveillance and control interventions. In 2001, WHO signed the first agreement with Sanofi, the then Aventis, and later with Bayer for donation of drugs and financial support. This agreement was renewed every 5 years, opening the door for a sustained collaboration to this date, contributing and resulting in significant progress that we observe today. Moreover, it was also extended to include the control of leishmaniasis, Buruli ulcer, Chagas disease, and yaws. This has contributed significantly in the overall control of these entities, resulting in a reduction in morbidity, disability, and mortality from these diseases. The fight against human African trypanosomiasis continued and even enhanced in the years when the first WHO Road Map in 2012 targeted to eliminate the disease as a public health problem, employing an innovative and intensified disease management approach. The pillars of this approach embedded enhanced active screening to detect and treat cases as early as possible, Many partners, including NGOs, bilateral organizations, foundations, regional and international organizations, have provided robust and unremitting support to the national control programs of the endemic countries. In the last 2 decades, more than 50 million at-risk population have been screened, and around 210,000 cases have received life-saving treatments. Health workers trained in effective diagnosis and management of cases, active screening, and surveillance. Most importantly, the program has demonstrated impressive achievement, bringing down the cases from 30,000 in 1999 to only 992 by the end of 2019, which is around a 97% reduction. The development of nifurtimox eflornithine combination therapy, as explained earlier, NECT in 2009, was a significant milestone in heart treatment. One of the landmark achievements recently in the research and development partnership is the development of the first ever oral treatment fexinidazole. WHO has accordingly updated its treatment guidelines and also included this medicine into the WHO essential medicine list. Fexinidazole now is donated by Sanofi through WHO to the eligible endemic countries. Just only last week, on 12 November 2020, member states have endorsed the long-awaited Ntd Road Map 2030. The roadmap will serve as a key strategic policy document guiding the global response to NTDs over the next decade. Encouraged by the gains made so far, the arrival of new intervention tools, and the cross-cutting approach of the new roadmap, elimination or interruption of transmission of the sleeping sickness due to TB gambians has been envisaged by 2030. This ambitious goal can only be achieved if we can enhance our joint effort through sustained and well-coordinated partnership addressing the challenges ahead. The attainment of total interruption of transmission is the only means to prevent any further future resurgence of this disease as it has been observed in the past. The roadmap also emphasizes the critical role of the endemic countries as owners and leaders of the elimination program and the essential role of other sectors to ensure multi-sectoral approach. Finally, I would like to reiterate that if we continue working together, we will be able to achieve our goal of elimination of sleeping sickness and making it history. Thank you.
Thank you, Dr. Daniel Daniel. So as you heard, very good news. The WHO and the member states have approved the 2030 Ntd Road Map, which is good news for all the diseases in there, including sleeping sickness. So now we are very lucky in these crazy times of COVID to have Professor François Chapuis, who's the head of emergency and humanitarian medicine at the Geneva University Hospital. And he's also in charge of all the emergencies. So it's fantastic that you took time out today to come and talk about sleeping sickness. And he's going to speak about his experience working on sleeping sickness as the advisor to Médecins Sans Frontières, Doctors Without Borders. Thank you. Over to you, Professor Chapuis.
Yes, thank you very much. It's actually a relief to get out of the COVID for a few minutes. Yes, I worked as a medical advisor between 1999 and 2015 for Médecins Sans Frontières. Here is a picture 10 years ago and 10 kilos ago, to be honest. It has been an extremely interesting experience in many aspects. And one of them has been really to follow the evolution of the clinical care of sleeping sickness patients. Next slide. So we are talking about a very remote rural areas of sub-Saharan Africa, and the two projects I've been involved in were in Democratic Republic of Congo and South Sudan. At the beginning, as mentioned by Francis Louis, Melasoprol was used between 2000 until 2002 in our programs. And it's easy to say, quickly to say that it kills 3 to 5% of the patients, but we have to go a little bit deeper into understanding what it means. Most of these patients, they were in relatively good condition. They came because they had some persistent fever and headache. And the next day, when you're doing the ward round, they were in deep coma because they had a brain hemorrhage or brain edema. So it was extremely tragic for the families and for the patient, of course, but it was also tragic for the caregivers because it was grossly violating the do not harm of the Hippocratic oath. And sometimes even we had outbreak of these encephalopathies during rainy season to such a point that we were postponing treatment for 2 or 3 months to try to save this patient from the complication, and we could achieve that only partially. Then came Aflonitine. Aflonitine is given, the picture, for 14 days as a monotherapy. We could use it from 2002 onward, 14 days and 4 times a day. So you can imagine in this kind of setting to have an IV line for 14 days, it was really prone to have bacterial infection, either local or systemic. So we really had to learn how to use it and how to take really drastic precautions not to have these superimposed infections. And also giving it 4 times a day means that at nighttime, you needed to have light and you needed to have a nurse present to prepare the infusion sets for these patients. And not to mention the enormous logistic constraint to bring the drug and the infusion sets, etc., to these very remote places. I'm talking about a box of almost a cubic meter and 35 kilos for only 2 patients. And so the next step was an immense step already, was the use of NECT. So it's Aflonitine, but given only 7 days instead of 14 days, and given only twice a day. So you did not have to give it at nighttime. And mix it, and you add oral nifurtimox. It's a very effective treatment, but still you had to keep patients in a hospital. So it means that you had, when you were in the field and doing all the diagnostic procedure, the patients in second stage, you had to transport these patients back to a treatment center. So this is the reason why, to improve and drastically improve access of patients to treatment, you have to bring the treatment closer to their place. And this is the real revolution of oral fexinidazole. It's a major step to give an oral treatment, even though we still had to confine the diagnosis by microscopy. But one of the big steps with fexinidazole is that for most of the patients, you don't need to do lumbar puncture, when the picture you saw before. And this is something that is a big simplification in the diagnostic tree. Is there a next step? Yes. If we had a very simple treatment, like a single dose treatment, extremely safe, maybe we can even skip the parasitological confirmation with a microscope and treat on the basis of a clinical suspicion and a serological suspicion with one of these newly developed rapid diagnostic tests. And maybe this is the next hope, and perhaps in one of the future editions of the Geneva Health Forum, that we can celebrate these acosaborol new compound that is being evaluated at the moment. So thank you very much.
Thank you, Dr. Chapuis. So as you heard, we've gone from like liters of drip. You know, before that we had a completely toxic treatment, which yes, it killed the parasite, but arsenic-based also really harmed the patients. And so now we've moved on to treatments which can be mainstreamed into the health system. So much so that, in fact, it's now part of the public health system, and the biggest program on sleeping sickness that we have in the world is in the Democratic Republic of Congo. And next on to speak is Dr. Eric Mwamba-Miaka, who is the medical director of the DRC National Sleeping Sickness Control Program. And we're not sure if he's actually available. I'm going to just see, otherwise Nathalie will do his presentation, because unfortunately he had his phone stolen. So whilst he's not here. Okay, so before we move to Nathalie, I just want to say that as you can see behind me, there is a logo for Sanofi. There should also be a logo for the Drugs for Neglected Diseases Initiative, which is the other partner in this, which was started with Médecins Sans Frontières money, and it receives a lot of public money, and it's the public with the WHO side of this partnership with Sanofi. So Nathalie, please, can you present a bit the presentation for Eric, Dr. Eric from the DRC, and then we'll move on to yours. Thank you.
Thank you, Samantha. So maybe if I can have the first slide, and hello, everyone. I think I'm presenting Eric's slide. So Eric is the director of the National Sleeping Sickness Control Program for the DRC. And that program is, as was mentioned by Dr. Louis just before, that program is the one that identifies patients and tests them, and then screens them, tests them, and then brings them for treatment. In fact, it was founded in 1968 at a time where there had been a lot of efforts to control the disease, and then the disease was coming back, and so there was a need to control the disease better. And so the government decided to put this program in place, which is it's what we call vertical programs, so a disease program which addresses a specific disease. And so that program was renamed PNLTHA, Programme National de Lutte contre les Nosomiases Humaines Africaines, in 2003. And its mission is to coordinate and organize the fight against sleeping sickness in DRC, but there are also other programs in the neighboring countries that are affected by sleeping sickness. And its objective is to decrease the morbidity, mortality to a level which is compatible with populations at risk for sleeping sickness. Elimination as a public health was declared, as a public problem was declared in 2020, and it's been the objective of the new roadmap, which Dr. Daniel just spoke before, is to eliminate transmission by 2020. So a very ambitious goal, but already we've seen a lot of effort and decreases thanks to combination of having good treatments, having diagnostics, and essentially having the screening and all the activities of the program. So what the program does is, Dr. Louis explained, they have these mobile teams, which are mobile because they are equipped by vehicles, and they go and reach to the patient by boat or by by boat, by motorbike, or by car. They go in villages and then do campaigns. They call for patients. All the patients have to come, and they are screened for the disease. What Dr. Miaka was going to present today is more the follow-up activities after fexinidazole has now been registered in DRC. No, I think it's the previous slide, please. There is a plan for access. And why is there, maybe the previous slide, why is there a plan for access? So we have to go back to what Dr. Chapuis said. In fact, fexinidazole is for the first time going to be a treatment that is given at close to where the family live, where the villages are, and it's not the same type of very specialized doctors who will treat patients with fexinidazole. Now that it's simpler to use, now that it's one tablet that you gave over 10 days, it can be administered by the program, by the healthcare workers, or the doctors living in more remote areas. They don't need to be so specialized as they had to be when they had to, to administer NECT. And so there's been a lot of training that's been planned, also for all the communities to understand that this effective oral treatment is a treatment you can give and how to give it. Fexinidazole needs to be administered with food. So there's a lot of advice and specific control that needs to take place, monitoring and how it's done. So people just need to be trained, those who will give it. And so there's been a program, which is a kind of pilot program in the provinces that was shown on the previous slides, which are the key provinces in the DRC, the Bandundu, Mujimai area, where there are the highest numbers of patients. And this is where this program is taking place to train the healthcare specialists and to monitor how the treatment is being administered. It was also a request of the European Medicines Agency that Sanofi has to comply with. So I think there was a slide that was showing how many training sessions have taken place since fexinidazole was registered. It's now been deployed, and there are two activities that are linked with that. So one is monitoring how many patients are treated, and I was told that there are about 63 patients who have now received fexinidazole as a post-approval, as a normal, if you wish, treatment, which is fantastic. And in addition to that, because it's a new treatment, there is an obligation, as for any treatment, to measure pharmacovigilance. But pharmacovigilance is done in two ways. Either it's done in a kind of passive way, where we've done some training in those remote areas where you train how to detect that something is not going well in relation with a treatment, and more importantly, because people know how to do that, but how do you report that? To what structure? And then the message goes up to the WHO and to Sanofi. And we're also doing more active pharmacovigilance, which requires collecting detailed information on every single patient that is receiving fexinidazole. So all of this is being conducted under the umbrella and the leadership of the National Sleeping Sickness Control Program for DRC under Dr. Eric Miaka's leadership. And then, of course, I think on his last slide, he's presenting the challenges and the future, which is, as also Dr. Chapuis said, we want to make sure that no patient with sleeping sickness is not detected. This is a disease that is anthroponotic, so it's transmitted from man to man. So, of course, you have to identify all the cases to treat them and make sure that the disease will eventually go down, and we will manage to keep it to a very low level and eliminate the transmission. So a lot of activities still need to be conducted by the program. And as the roadmap is also suggesting, is maybe as there will be lower cases, organize structures or activities in a more vertical and horizontal way, so that you keep momentum and you don't lose the chance of giving treatment to every single HAT patient. I think I'll stop here for that presentation.
Thank you. So that was Dr. Nathalie presenting Dr. Eric Mwamba-Miaka, the head of the sleeping sickness program in Democratic Republic of Congo, who unfortunately couldn't make it due to some logistical issues. So now we're going to go back to Dr. Nathalie Stroop-Bourgaert, who this time is going to speak on behalf of herself and the other partnership in this new treatment development, which is Drugs for Neglected Diseases Initiative, where she is the director of neglected tropical diseases. Thank you. Nathalie, over to you again, this time as you.
Thank you. No, I think, so maybe what I'd like to do is just present a little bit how we work and what we've done in addition to everything that's been said before. So Drugs for Neglected Disease Initiative is a not-for-profit R&D organization, and we rely essentially on partnerships. We were founded in 2003 for the specific motive that François Chapuis presented before, because Doctors Without Borders working on sleeping sickness were facing the neglect of having to treat with melarsoprol, of the fear of administrating a potentially life-saving but potentially death-killing drug, and the fact that the market, there was no incentive in the pharmaceutical industry, for the pharmaceutical industry to directly engage and fund all the R&D activities that are needed to get to a new treatment. So there was a need to fill this gap for neglected patients. Sleeping sickness is one of those diseases. And the way we work is that we build partnerships, we define a few diseases, and for sleeping sickness, for each disease, we start by developing what we call a target product profile. This means that we bring together all the researchers working in sleeping sickness. Primarily, we bring together those that are treating sleeping sickness, the doctors, but also the lab technician, the nurses. We bring the NGOs, of course, MSF. We bring the ministries of health, the national programs. We bring them together and we discuss together what is it, and we discussed what is it that is needed to manage sleeping sickness. So this is how we, starting, and we did that at the time of where NECT was being developed, Nifortimox Aflonitine combination. And at that time, the community said, well, NECT is a treatment you give to the second stage of the disease, when patients have these neurological symptoms. But before that, they will receive, if they have not reached that stage, they will receive pentamidine, which Dr. Louis mentioned as an injectable intramuscular disease. And we asked the community, what is it that you want? What is it that's needed to treat patients? And they said, we need one treatment, oral, that you can give and to treat both stages of the disease. Because to differentiate between the two stages, you need to do the lumbar puncture, which is painful, which is done like this without anesthesia, and is something that made people run away from the screening campaigns because they did not want to get melarsoprol, but they don't want to get a lumbar puncture either sometimes. So we developed this TPP. The TPP said an oral treatment that would be safe and that you would be very effective in the most severe stage of the disease, and of course at the same dose in the other stage. So what we did, we went back to our research colleagues. We started building partnerships with Swiss TPH and other groups like this, who started looking at existing molecules. So nitroimidazoles were antiparasitic drugs. We screened a library of 700 compounds, which means in the lab, there was the trypanosome, the parasite of sleeping sickness, was tested against a huge number of molecules to see if the molecules could prevent the growth of the parasite and kill them. And based on this, we identified fexinidazole. So fexinidazole was then, at that time, the NDI is an R&D organization, but we need partners to deploy, distribute, register the drugs. And we had long-standing partnership already with Sanofi on malaria. And on the other hand, Sanofi was already very much active in sleeping sickness with melarsoprol, eflornithine, pentamidine, and with support to the WHO. So very naturally, we decided to bring and build this partnership with Sanofi, whereby we would continue to develop fexinidazole in clinical trials, and Sanofi would be in charge of the follow-up activities. And this is what we did. So for 7 years, we developed fexinidazole. We started by doing phase 1 studies in sub-Saharan African volunteers. And then we moved to the clinical studies in the DRC.
Hi, sorry, Nathalie, can you wrap it up, please? Because we're running a little bit out of time. Just if you could make your main points. Thank you.
I will. So those are my main points, that we bring partnerships. We worked with the PNL-THA, and it was with the support of the researchers in the DRC, with a lot of training, but a lot of commitment and an incredible team in DRC, research team, DRC and a little bit in Central African Republic with MSF, that we managed to bring fexinidazole to Sanofi for registration. And we will continue with another drug, but I'll stop here. Thank you.
Thank you so much, Dr. Nathalie Struburga. So as Dr. Nathalie was saying, really essential to all these are the national control programs. And unfortunately, Dr. Eric Mwaba-Miaka from the DRC couldn't make it. And then also, obviously, the World Health Organization. So I'm going to take a second to say, please, 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 all of you audience out there, think up some very tough questions. We have the best of the best here on sleeping sickness, and we want to keep them on their toes. So please, we're expecting some great questions from you all. So without further ado, we're now going to move on to our second video, which shows you exactly how these amazing treatments, which now work on, both stages, or how they get from the laboratory, from the factory to the patient's hand. So we're going to look at a very short video, which is End the Neglect of Sleeping Sickness. Thank you.
At the beginning of 2020, fexinidazole, the first all-oral treatment for sleeping sickness, was rolled out in the Democratic Republic of Congo. We start in France, where the treatment was produced and released by Sanofi and shipped to Democratic Republic of Congo by Médecins Sans Frontières Logistique. The World Health Organization and DNDi collected the shipment in Kinshasa. It was delivered by the National Sleeping Sickness Control Program to the most remote areas of DRC where people are at risk of sleeping sickness. The journey from the laboratory to the patient's hand was a long one and is testament to strong partnerships between Sanofi, DNDi, the DRC Sleeping Sickness Control Program, and many other partners. It is also a testament to the power of innovation in fighting neglected tropical diseases.
Thank you. So that was the End the Neglect of Sleeping Sickness, a short clip of the video. And now we're going to move to Dr. Amy Fall Ndao, who is the Global Health Medical Lead for Africa for Sanofi. And Dr. Amy is joining us from Dakar. Merci, Dr. Amy. Sorry, volume, we can't hear it. Sorry, Dr. Amy. You need to put your microphone on and start again, please, because unfortunately we missed the start of what you were saying. Merci.
Merci, bonjour à tout le monde. Good morning, assalamu alaikum from Senegal. Thanks to Samantha for giving me the floor, and thanks to Geneva Health Forum organizers for giving me the opportunity to participate to this virtual event on behalf of Sanofi Global Health entity. It's very important to highlight the historical partnership which lead to this great achievement we are celebrating today. As part of our long-standing commitment to the fight against NTDs in general, and more specifically to support the elimination of sleeping sickness, we are proud to be part of this great initiative. The originality of success of the unique collaboration between Sanofi and DNDi is that we have been able to work together and in a complementary way despite our different missions and priorities, but always mobilize around the same objective, to save patients' lives. Fexinidazole Innovative Development Project has demonstrated the effectiveness of public-private partnerships to support international efforts to eliminate sleeping sickness with well-defined roles and responsibilities. There is the NDI responsibility for preclinical, clinical, and pharmaceutical development, Sanofi in charge of industrial development, registration, production, and distribution. The World Health Organization leading the activities of the HAT programs and supporting of the project, and the National Sleeping Sickness Control Programs, playing a major role in both the control and surveillance program. Besides the 11 years partnership with the NDI, we are also proud to celebrate this year the 20th anniversary of our collaboration with WHO. Thanks to this partnership, we achieved significant progress in the control of the disease. However, we must remain vigilant. A lower number of cases poses a challenge to the way the disease has to be tackled. Last cases are the most difficult to reach. To avoid risk of rebound, and we all know that we had an experience in the past, and reach sustainable elimination, we must remain mobilized, especially since the COVID-19 pandemic will have an impact on our achievement. The reason why Sanofi and DNDi have taken their collaboration one step further by signing recently an agreement for the development and rollout of an innovative single oral treatment issued from DNDI's lead optimization program, acoziberol. Acoziberol, once approved, could give a radical boost to the final stage of the sustainable sleeping sickness elimination by 2030. By renewing our collaboration with WHO, we will continue to fight against sleeping sickness through drugs donation and the support for capacity building and patient screening. We strongly remain committed with all partners and the WHO leadership to the sustainable elimination of sleeping sickness. Thank you so much for your kind attention.
Thank you so much, Dr. Amy Fall-Ndao, Global Health Medical Lead for Africa for Sanofi, joining us from Dakar. So now we're going to open up the floor to some questions. And I'm just looking right here, sorry. Okay, so one of the questions that's come through is, were there any specific challenges in the field of, sorry? Oh, sorry, we're also having some logistical issues here, not just DRC. Okay, so were there any unexpected challenges of the treatment as the treatment and diagnostic tools shifted essentially quite rapidly in the space of 20 years? So normally I would ask that to Dr. Miaka, but maybe I might go first to the World Health Organization and then maybe to Natalie or Dr. Amy. Daniel? We can't hear you. No.
I said, can you repeat your question, please, Samantha?
From the point of view of WHO, were there any specific or unexpected challenges in getting this treatment to change essentially quite rapidly, treatment and diagnostics in the space of less than 20 years? And, you know, what other positive things do you see moving forward? If we could keep the answers brief, thanks, because we don't have that much time. Thank you.
Thank you. There are definitely several challenges in both the intervention of human African trypanosomiasis for control and elimination, as well as in the research and the development of drugs or diagnostics. Most importantly, I think I would like to mention the insecurity-related challenges that is prevailing in most of the endemic areas. But in addition to the insecurity, finance and lower attention in some areas given to this disease is also a challenge for both the intervention and the development. However, despite these challenges, the partnership, having this long-standing partnership, have helped in bringing up important developments, as mentioned during the discussion, in development of new drugs, new rapid diagnostic tests, as well as interventions. Over to you.
Thank you. So, Natalie or Dr. Amy, did you have any comments on some of the challenges in moving to treatment, such new treatment and diagnostics? Natalie? Dr. Natalie?
Maybe, yeah. I think, well, obviously having a simpler treatment is not a challenge. It should be seen as an advantage. The challenge is maybe the mindset change so that, you know, you understand that an oral treatment is as good as something that is injected. And we're trying to understand how we can help the communities and contribute to a better understanding and manage what the communities think about this. That's something to be done. On the diagnostic side, I would say that we're coming now, there's a lot of research by our colleagues from FIND and ITM on rapid diagnostic tests. That will be very good. However, there is still a need to be sure that when you say a patient has sleeping sickness, the parasite is seen. And this is very specific knowledge and expertise. The challenge is to make sure that this expertise continues and that as cases decrease, we still have those very specialized lab technicians that will continue to transfer their knowledge to the next generation. I think that's a key challenge.
Thank you. So we've heard from Dr. Daniel about the challenges of working in war zones, ongoing conflict areas, and then from Dr. Natalie about the importance of safeguarding some of this fantastic experience that so many of the unnamed doctors and nurses and health workers in the depths of the jungle in DRC, very difficult areas to work in, are facing, and that they have this unique expertise. Thank you. So now I'm going to give another question, please, to Dr. Amy Ndao, which is, what was the biggest challenge when private stakeholders lead a public health response for an NTD like sleeping sickness? And maybe Natalie can also comment. Thank you.
Thank you, Samantha. I think that the biggest challenge when you try to make all partners together is to be sure that you have a good collaboration and each of them are doing his part in the partnership. But for me, it's really an opportunity for sleeping sickness because you are not far from the elimination because we are now eliminating the public health. We reached the public health elimination of sleeping sickness. But as said by Natalie, the thing that the most challenge we will have is how to reach the last patients, how to keep mobilized, how to keep the funding, and how to keep everyone focused on this objective together. I think that it's a great opportunity for all of us now, but we need to keep the momentum and to keep mobilized to reach the objective.
Thank you. So from Dr. Amy Faldao, the importance of keeping the focus. It's not because we've now gone from 20, down to just under 1,000 patients that we can stop focusing on this, because that's often when it's the most difficult, is to get those last patients. So we have another question here, which I will open to the floor. It would have been great for Dr. Miaka, but he's not here. Have you considered the option of peer-to-peer education of health professionals in the future, or introducing some training content into formal education? Maybe, Dr. Daniel, you can, because that's kind of a WHO thing, is looking at how ministries of health continue the knowledge and keep up with the training. What are you suggesting on NTDs for diseases like NTDs for peer-to-peer or other education? Thank you.
I think continuing education in form of community education, in form of formal trainings, in form of peer education is essential. WHO, in collaboration with several partners working on the ground, is conducting several trainings, especially as Natalie raised, one of the major challenge is losing expertise in the field when the disease is, getting lower and lower, and in the field when we start to see very few number of cases, the new expertise are not coming into the same field. So we are losing, be it in case management, not only in diagnosis, we are losing expertise. So we need to continue providing trainings, not only ad hoc trainings, but also trainings included in the curriculum of health workers in endemic areas. And in the Ntd department is now using the technological advances and making trainings available online in smartphones for all essential neglected tropical diseases that will help the continuation of the education, the health promotion, and the training for health workers, for communities, and other partners involved in the implementation of the program.
Thank you. And one other question, very short, please. And what I'm going to ask is to quickly go around all the panelists before we have the concluding little video. If you could please tell me in one sentence why you're so excited about the progress that's been made, or what's the most exciting thing for you on the sleeping sickness progress. But I want to start with Daniel. Before you tell us your one sentence on what's exciting, we have one quick question here. How can the animal reservoir be eliminated? And please tell us your reasons for hope and excitement, and then we'll move on to the others. Thank you. Quickly, everyone. Thank you.
Okay, first the animal reservoirs. Yes, we have some cryptic infections and infections observed in the animals for human African trypanosomiasis. There is a collaboration with African Union and FAO and the International Atomic Energy in order to address infections in animals, especially for the Rhodesian C4, and the experience that is gained from this multiple partner and international organizations can be applied for this in future. Then there will be a role for vector control as well. After saying
Reason
that,
to be excited?
yes, with regard to the reason, I am very excited that we are, first of all, bringing significant 97% reduction in a very deadly disease. That has been killing several thousands of human lives and making significant economical losses. That is a big excitement, and getting an oral treatment is also another excitement for me for this deadly disease.
Thank you. Dr. Chapuis, your reason for excitement. Less than 1 minute, please.
I think there is always a reason to celebrate every time there is a new diagnostic, treatment, or control tool that improves access of patients to care and cure. So much less than 1 minute.
Yep. Dr. Francis Louis, une phrase. Pourquoi vous êtes excited about the new treatment?
Parce que c'est la preuve que si on travaille tous ensemble, on obtient des résultats magnifiques et surtout très rapides. Et c'est un très grand espoir pour l'Afrique et pour la maladie du sommeil. Merci.
Merci. Dr. Fall, une phrase. Pourquoi vous êtes contente? OK, your mic. On n'entend pas là.
J'ai dit que je suis très contente parce que c'est vraiment notre engagement à Sanofi Global Health, c'est améliorer la santé des populations les plus démunies. C'est notre engagement et cette réalisation avec ces traitements dexamethasone et alcoldurone répond exactement à cet engagement et c'est l'objectif qu'on s'est fixé. Ça améliore réellement et ça change complètement la qualité de vie des patients. Voilà ce qui me motive.
Merci. Nathalie, très, très vite. 10 secondes.
La même chose, mais aussi dire que peut-être que les patients auront un peu moins peur d'avoir un traitement parce qu'ils n'auront plus besoin d'avoir la ponction lombaire. Et l'autre chose, c'est la satisfaction de montrer qu'on peut, comme a dit le docteur Louis, on peut faire de la recherche très compliquée dans des zones où on ne pensait pas le faire et ça donne beaucoup d'espoir pour toutes les autres maladies tropicales négligées pour lesquelles il faut continuer toute cette recherche.
Merci. Et maintenant, thank you everybody for joining us on the Sleeping Sickness Geneva Health Forum session. And the final word is going to the representative of the permanent mission of the Democratic Republic of Congo, Mr. Serge Musenge, who has sent us his statement by video. Thank you, everybody. I was Samantha Bolton. This is the Geneva Health Forum on sleeping sickness.
Mesdames et messieurs, distingués participants, la République démocratique du Congo voudrait d'abord remercier les organisateurs, notamment d'Ntd et Sanofi, pour avoir pris l'initiative d'organiser cette session à l'occasion de ce Geneva Health et dont le thème est vers l'élimination de la maladie du sommeil. Pour rappel, la République démocratique du Congo est parmi les pays qui se sont engagés dans la lutte contre la trypanosomiase, et cela sans relâche, évidemment avec l'accompagnement des partenaires dont Ntd. Et on note depuis cette lutte des avancées significatives, notamment 1. La réduction des cas de malades. Nous remontons en 2013 avec plus de 5000 cas rapportés pour 604 cas en 2019, et ce grâce aux efforts du gouvernement de la République démocratique du Congo qui, par le ministère de la Santé, a fait de cette maladie un problème de santé publique. 2. La mise en place de la journée nationale de la trypanosomiase le 30 janvier 2020. Notons en plus que la mise à la disposition du gouvernement congolais en partenariat avec la Fondation Bill Gates et le gouvernement belge de TDR et des tests sensibles avec l'IMT, le lancement de fexinidazole, nouveau médicament pour lutter contre la maladie, réconforte la position du gouvernement de la République démocratique du Congo dans son objectif d'arriver à l'éradication d'ici 2030 de la trypanosomiase. Je vous remercie.
De HUG, de l'OMS, de Paris. Merci.